Hello all, this is Evan Laguris with Illinois Eye Center here to share my Xen Ab Externo technique. This technique is a technique that takes a little longer than the ab interno approach because of the conjunctival cut down. However, the cut down I think provides for a more precise placement of the Xen, which in theory should allow for more predictable IOPs and getting us near those filter IOPs that we're desiring in some of these patients. So let's get started here. I like to make my conjunctival opening L-shaped here to give us a little more freedom when we're closing it. We're going to be very careful and to open both the conjunctiva and the underlying tenons. This patient has particularly thick tenons, and we really want to make sure that we're dissecting both away from sclera because we want to place the Xen when we're doing an external approach right on bare sclera. Unlike the internal approach where usually we're trying to get it just barely under the conjunctiva, totally free of the tenons underneath. So we're going to be very careful here, really make sure that we free the tenons all the way around. We're going to go in both directions here. I'm going to use a Blumenthal to check that it's free. And we're going to find that nasally here we still have some adhesions, which we're going to go back and free up with scissors. Again, really want to have a nice wide pocket, and this Blumenthal is a nice confirmation tool to confirm that you don't have any adhesions that remain. So we're going to free that up. Then we're going to do some cautery. I really like to have a nice clear field when I do these insertions because of the precise nature of how we're going to place it. And so after we get those adhesions freed up, we're going to do some cautery to give ourselves a better view. Once we do our cautery, we're going to make some marks with the calipers. I like to mark right at the surgical limbus, right where that blue line and the white meet on the sclera, and mark back 2 millimeters from that as well. That mark anteriorly is going to be where we're going to turn our hand as we insert the Xen to a more downward position to give it a good angle. And the mark posteriorly is going to be where we're going to start our Xen into sclera as we tunnel. So here we are placing our mark. Right at the junction of the blue and white, and then 2 millimeters posterior to that. I use a 0.12 to hold the sclera. Unlike a lot of other techniques, I don't free my releasable, my bridle stitch. I keep the bridle stitch there right when we get to that anterior mark, we angle in, and then very gently, kind of like we're trying to leave a piece of cake on a spatula on a table, we release the Xen. Unlike the internal approach where you keep the Xen abutted until it's all the way retracted, you are pulling back as you start to retract the needle so that you don't flick the needle. Now, to get that Xen on bare sclera, very often what I'll do is I'll tease it back in so that I don't bend it, and then tease it back out of the eye so that I know it's nice and straight. Well, if I'm not sure it's straight, I'll confirm it by using the end of the cannula to check to see that it's straight. Now we're going to confirm position here, and you'll be able to see the Xen just anterior to the TM and about 1.5 millimeters in the center of that mirror. Really, really good placement there. This is exactly what we want to see. And now we're going to close this. I close these using a 9.0 Vicryl monofilament, much like I do my trabs. However, very often with these, you don't need to run these across, and you can close them with a single wing. Really, it depends on how the conjunctival opening looks anterior when you begin to close or when you're finished with that first stitch. And if that first stitch doesn't make it nice and taut, then I will run this 9.0 across using a modified Wise closure. So this is how I do this. I place that 9.0 stitch just outside the bleb anterior there, and then we're going to basically make kind of a purse string style grab to start with 3 to 5 passes through the edge of the conjunctiva, trying also to grab underlying tenons to pull that forward as well. Again, tenons is not our friend with Xen surgery. We want that tenons up at the limbus, not back by the tip of the Xen so that it doesn't clog the Xen. And I'm just going to trim it to kind of an appropriate length here, and then we're going to close this using a 3-1-1-1 technique. and then we'll see if it's nice and tight. And if it's nice and tight at that point and holds water when we inject BSS, then we'll go ahead and cut it and be done. If it's not, then we'll go ahead and run it across. When you work with this 9.0 Vicryl monofilament, it has a lot of memory. So I would be very careful on how hard you tug on it, because if you tug on it, it's going to be like dealing with fishing line, where it gets very, very curly. Not as fun to deal with then. And we can see already as this is closing that we still have a little gap in our conjunctiva anteriorly there. So I'll probably run this across just to be sure that we have a nice watertight seal. Because the opening to the Xen is so far back, very likely that it would have been okay, but just being safe, again, takes a few minutes in the OR that might save you headaches months down the road. I didn't show that modified Wise as we went across, but basically it's just a modified Wise technique. Now we have one nice running 9.0 nylon suture. We're going to inject BSS and make sure that we're watertight, and we're going to look for our bleb to form. If our bleb doesn't form, obviously then at this point, well, you're kind of stuck going back and figuring out why it doesn't. We can see as I press down with the cannula, it pops right back up because we've got a nice bleb forming. You can see it forming nice and posterior. These are these beautiful diffuse blebs that we get with Xen. I inject 40 micrograms in almost all of my Xen cases of mitomycin C. That's usually mixed with an equal mixture of Lido with Epi. Little discomfort for the patient there. I feel sorry for that. I like to inject as posterior as possible when I do this, so that if there is any buttonhole that remains, it's covered up by the eyelid. I also inject about 0.5 to 0.3 of Decadron, depending on what it looks like at the end of my cases, directly into the bleb, which I think, again, we want to minimize any scarring we can early on to give this bleb the best chance of survival. Thank you all for watching, and this is my Xen Ab Externo case. Thank you.